Hello and welcome to the Quality Compliance Systems Q Talk on safeguarding. I'm Philippa Shirtcliffe, Head of Care Quality at QCS. I'm a registered nurse and have been working in domiciliary care for the last 20 years. A considerable number of these years have involved having a national safeguarding role within a large health and social care company. I'm joined today by Leah Cooke, the Residential and Nursing Care Lead at QCS. Leah is a registered nurse and she's also a specialist advisor to CQC. Hello, Leah.
Hi, good afternoon, everyone.
So moving on, we're going to talk about safeguarding today. We don't have all the answers, and safeguarding is such a large area. The purpose of today is to develop further thinking about how to improve responses to safeguarding, about the importance of partnership working. The session is live and there'll be a question and answer session at the end, but do feel free to ask any questions that you might have throughout the Q Talk by using the comments box on your screen. So the themes today that we're going to cover are the safeguarding framework, the Care Act 2014, types of abuse and emerging language, good governance. I'm particularly going to look at the links between safeguarding and the quality of service provision, competencies and training, and positive risk taking. Everybody, regardless of their role in health and social care, has a responsibility to promote the right for the people that we care for to live a life free from harm or abuse. So Leah's going to give you a little bit of an insight into the safeguarding framework. We can't talk about safeguarding without giving you a bit of information about the background. Leah, do you want to talk about the framework?
Okay, so if we can recall then, the government first introduced and recognised adult abuse back in 1993, and they released a document through the Department of Health called Elder Abuse. And really the tone of the document suggested that adults were to be protected by organisations that cared for and supported them. Then 10 years later, we had the release of the No Secrets guidelines, and really the intention of the document was to develop and implement multi-agency working, and that was by production of policies and procedures that were bound within adult protection frameworks. And the guidance required that all local authorities had a multi-agency policy embedded by the year 2001. And although there were no statutory powers to this, there were policies and procedures produced across the country, and these were then seen as good practice guidelines. The problem was, however, with the No Secrets is because it wasn't legislative, safeguarding didn't function as it should, and people who did need to get protected were being missed, or people were being overly protected, and from this came really high profile cases such as Orchard View, the Winterbourne View, and then we had the Staffordshire inquiry that resulted in the Francis report with recommendations. And following much consultation, there was an agreement to reform the adult social care law, and this included having the new adult safeguarding framework. And then in 2014 along came the Care Act. And again, from this there have been some further landmark safeguardings, which include the Jimmy Savile case that resulted in the Lampard inquiry. So Philippa, probably at this point it's worth mentioning maybe the new terminology involved in safeguarding.
Yeah, I think one of the difficulties in relation to safeguarding is the use of language, and people often use different languages, and you'll notice if you look at local authority policy documents, language is slightly different. So the term safeguarding adults is used to describe all the work to help adults with care and support needs to stay safe from abuse and neglect. And the term safeguarding adult now replaces the words adult protection. The word adult at risk of harm and neglect has been used to replace vulnerable adult, which first occurred in around 2000. And the reason why there's a move away from using the term vulnerable adult is because it can wrongly imply that the reason for abuse lies with the adult that's being abused, and it assumes that the simple case of being old or having a disability makes somebody vulnerable, and this isn't the case. It is still okay to use the term vulnerable, and so for example we may refer to somebody who is vulnerable to a particular type of abuse or harm. For example, somebody's vulnerable in relation to radicalisation, but that there's often things in the background that lead you to use the word vulnerable. So Leah's talked about the Care Act, and one of the things that I wanted to focus on particularly today were the Care Act principles. There are 6 principles, and obviously I'm not going to go into a huge amount of detail here. I'm sure most of you are aware of what the 6 principles are. You know, there's empowerment, prevention, proportionality, protection, partnership and accountability. I think one of the important things to highlight with the 6 principles are the use of the language in them, that they start with I am. And this is very much about a person-centred approach to safeguarding. I receive clear and simple information about what abuse is, how to recognise the signs and what I can do to seek help. And from a provider's perspective, it's really important to review these and reflect on these and see when you're providing information to service users, for example, at the start of a service in your service user guide, or when you're doing training with staff, making sure that you can reflect the principles, the 6 principles of safeguarding within your documentation, within your policies and procedures, within your training, and also that it filters through all the aspects of governance within your organisation. So we haven't talked about the Human Rights Act, and we can't talk about safeguarding without referring to the Human Rights Act. So it's an integral part of safeguarding. Obviously, the Human Rights Act includes the right not to be subject to torture, inhumane or degrading treatment, and that people have a right to enjoy a private family life and home life without any unjustified interference from a public authority. So consequently, any serious abuse becomes a violation of the Human Rights Act. And while risk-averse or disproportionate professional responses can be a violation, if abuse takes place in a family or a home, then the local authority has to think about balancing the rights of the individual and their family life. And this can sometimes mean balancing the conflicting rights. I'm going to talk later about positive risk-taking. But Leah, do you want to talk about what the aims of safeguarding are?
Yeah, definitely. Okay, so what are we aiming for here? Well, the first one really is to promote an outcomes approach in safeguarding that works for the people we're looking after, and it provides the best opportunity and best experience and outcome. We also want to safeguard people in the way that we support them into making choices and having full control in the way that they choose to live their lives. And I refer now to the Making Safeguarding Personal statement. And I'll come back to that in a minute. We also want to raise awareness so that professionals, other staff and our local communities as a whole can play their part in preventing, identifying and responding to abuse and neglect. And as we've already said, it's everyone's responsibility. And finally, we want to prevent harm where we can and reduce the risk of abuse or neglect to adults with care and support needs. So to summarise, really, it's about the people and the organisations working together to prevent and stop both the risks and the experience of abuse or neglect, but also at the same time ensuring that we monitor and keep an eye on the well-being, and we promote this fully, and including where we can ascertaining views, wishes, feelings and beliefs before we determine any action that we must take. And just for your interest, really going back to the Making Safeguarding Personal document, when it went out to consultation, they drew up a number of conclusions from it, and that really was that safeguarding has to be built on empowerment and listening to the individual's voice. And we all have a role to play in empowering those individuals. Safeguarding adults is not similar, and it's not the same as child protection, and adults do not want to be treated like children, and they certainly don't want a system that was designed for children. And finally, there was a really huge drive and a conclusion around those that lack capacity and how we make sure that they are effectively represented. And I think summarising that, these conclusions are really important considerations when we go again to talk about risk taking later. So Philippa, how do we even begin to achieve these aims?
I think as providers, domiciliary care, care homes, nursing homes, whatever your background, I think it's really important that your staff understand their roles and responsibilities, and that they also know how those roles and responsibilities work as part of the wider multidisciplinary team as well, and that your documentation reflects that, but staff also know how local authority safeguarding procedures work in relation to theirs as well. So whenever you have your own safeguarding procedure and policy, your local safeguarding procedure will always take priority, and it's important that staff know what their role are and how to access safeguarding support outside of your organisation. And that leads on to creating a strong multi-agency framework for safeguarding. So not one organisation can support somebody, it's a team approach. Local authorities use information from a variety of sources when they're considering how much involvement they need and how much they need to protect an individual. And there's also achieving another aim is to make sure that people understand that there are very, very strong links between good safeguarding practice and the quality of service provision, and that having a high quality service will help reduce some of the incidents that may arise, or safeguarding incidents that may arise. Not saying that you can prevent every safeguarding incident arise, and I think, you know, one of the important things to take away from today is that, you know, we are human, things do happen, but there's a recognition that if things do happen, that we follow a proper process, that we reflect on the practice that's taken place, we do root cause analysis, and we apply lessons learned to try and prevent things arising again. We've already talked about the change in legislation, and I think that's been one of the key drivers for the change in language. We're going to talk a little bit now about the types of abuse and emerging language, and it's important that your staff understand the different types of abuse and the behaviours as well as abuse that are on your screen. It's probably something that you're doing day in, day out, and also when you're delivering training or you're doing your training here. But I think what's really important to understand is that, you know, these are all in their separate little boxes, but the categories do overlap. For example, under domestic violence and abuse, forced marriage may sit under that category. Modern slavery includes slavery, human trafficking, forced labour and domestic servitude. It can also include sexual exploitation. In terms of the emerging language, cuckooing is one that is increasingly becoming apparent within sort of the safeguarding language, or county lines or going county, and it means groups or gangs using young people or people who may be more vulnerable to carry and sell drugs, and this is the county lines, from borough to borough and across county boundaries. It comes from, I don't know whether you watch Spring Watch or Autumn Watch and know a little bit about the bird, the cuckoo. This is where cuckooing comes from. And in terms of adults and safeguarding, the gangs may move into an individual's home. They use the property for drug dealing and often leads a vulnerable person to be left homeless. They may also send people from their own area to stay at a house and then distribute drugs, sometimes known as a trap house. And the impact of this on people who are vulnerable leads them to become indebted to gangs and groups. They can be forced into labour and exploitation to pay off debts. And at local, there's risk to people as well in the local area as well. Another language I want to raise with you, emerging language, is contextual safeguarding. Now, this is something that's actually linked to child protection, but I thought it's probably worth mentioning given the number of people that we've got. University, or a lot of work's been done by the University of Bedfordshire. And it's an approach to understanding and responding to young people's experiences of significant harm beyond families. It recognises that the different relationships that young people form in their neighbourhood, their schools and online, can feature violence and abuse. And parents and carers have little influence over these contexts, hence the phrase contextual safeguarding. And young people's experiences of extra-familial abuse can undermine parent-child relationships. Now, I just wanted to run a quick poll, because obviously we've introduced some new language there, contextual safeguarding and cuckooing. I just wanted to ask, have any of you heard of the word cuckooing in relation to safeguarding? And do you think your staff would know how to respond if there were ever an issue? So it's a straightforward yes and no. So your poll's now open on the side of your screen. We're seeing the figures coming through now. It's quite interesting. Yeah. The figures are coming through, and there's a real big split there. At the moment, we're at 80% people saying that no, they haven't heard of cuckooing. With 23%, it's varying again, it's actually going up. We've got 81% of you voting, so thank you very much for those feedback. Yeah. It's really interesting, and I think, my role here at QCS is to write policies and procedures, and I think it's, what we try to do is stay ahead and identify where there are emerging themes. And I think you may start to see, certainly around the cuckooing, that this language will start to emerge in terms of safeguarding and expectations around what you train your staff and how you train your staff, and make sure that they're aware of how they need to respond. And I think when you strip it back, it's all around good communication. Definitely.
Thank you so much. I think that's everybody in. So that's a final result of 77% on no and 23 on yes. So thank you for participating. That's really interesting. Yeah.
So we talked earlier about the aims of safeguarding and making sure that the links between safeguarding and good service provision are known. With this in mind, a safeguarding policy and procedure shouldn't be seen in isolation as a standalone document. And one of the things that I say to people is, you can't just give somebody one single safeguarding policy and document on its own. You have to see it as part of a bigger picture. This is why we've got the slide in front of you as an umbrella, and I know it sounds very simplistic, but from my personal view, I think it's a really good way of showing people that safeguarding is an umbrella term for lots of different aspects of how you deliver your services, and it's an umbrella for the other activities that take place within your organisation. So you can't, for example, talk about safeguarding without talking about medication management. You can't talk about safeguarding without considering what's your no reply policy in domiciliary care, or whistleblowing, or consistency and continuity of care. And all these aspects under this umbrella all lead back and all may trigger safeguarding incidents. So we talk about, safer recruitment. If you don't get your DBS process in place, or you've not taken up references, it may ultimately result in safeguarding issues arising further down the track. For example, the no reply. I'm sure you're all aware and have been involved in instances where there's been a care worker who hasn't followed a no reply process, and that can sometimes have devastating consequences for a service user. I think we've talked about quite a bit about legislation, and we talked earlier on at the start of this Q talk about the documentation and the legislation and the good practice guidelines that were published. And I think safeguarding hasn't always, for adults, hasn't always been on the same level as child protection. And legislation for adults has been fragmented over the years, and it's now starting to come together. And I think one of the key milestones for us has been this year, in August this year, has been the publication of a new document by the Royal College of Nursing, who collaborated with other organisations and bodies such as the British Geriatric Society, the Royal Pharmaceutical Society, and they've published a document called Adult Safeguarding Roles and Competencies for Healthcare Staff. And that was published in the middle of August this year. Now, the title's a little bit misleading. It's not just focused on healthcare staff, and when you go into the front of the document, it does also refer to social care staff as well. Now, I'm not going to go into a huge amount of detail, but this document is basically the blueprint for how you will be needing to train your staff over the next few years. There's no expectation that you will have completed the mandatory levels of training within the first year, but there is an expectation that by 2021, when the document comes to be reviewed, that you will have the mandatory training framework in place for your staff. And it's similar ways that they do in the intercollegiate document for children. They refer to different levels of staff, and that looks at the roles and responsibilities and the competencies. And it gives the guidance on the types of training and the length of training. It's a really important document to have a look at. And I think what you will see over the coming months, over the coming years, through tendering, through CQC inspections, is that you will be expected to have some systems in place to make sure your staff, and you can benchmark against this in terms of safeguarding training. So I strongly recommend you get hold of the document and have a look at it. In terms of safeguarding, we've talked about it being an umbrella term, and there are different aspects to it in terms of good governance, and one of those areas is around pressure ulcers. Leah's going to talk a little bit about this. It's one of her favourite subjects. So she's going to talk to you a little bit now about pressure ulcers in relation to safeguarding.
Yeah, absolutely. Gets me the chance to put my nursing hat back on, but really I want to talk to you about the new protocol that was launched in January this year. And the foundation really was because it was widely acknowledged that the number of referrals to safeguarding adults boards was really high in relation to pressure ulcers or any changes in skin integrity, and they felt that nationally there was a need for a safeguarding protocol. And I would certainly again advise you getting a copy for your own reference, but I'll give you a very brief overview of it now. So its aim really is to assist managers in health and social care to provide a timely and appropriate response to people at risk of pressure ulcers. The concerns really are that pressure damage can occur as a result of neglect, and in the protocol's terms this is defined as the deliberate withholding or the unintentional failure to provide appropriate and adequate care and support. And this includes neglect, and it also includes acts of omission, such as ignoring medical support, emotional support, and providing physical care needs, and also accessing here some educational services to be able to provide the correct management and treatment. So the main emphasis of the protocol is to determine if the pressure damage was avoidable or if it was unavoidable. And to be avoidable, this means that the organisation didn't do one or more of the following. So they either didn't evaluate the individual's clinical condition and their pressure ulcer risk factors, or they didn't define and implement interventions or revise and review those interventions if they noticed that there was no change, improvement, or there was some deterioration. So to simplify that and sort of consolidate it all really is in other words, if you can really demonstrate and evidence that you did everything possible to try and avoid the pressure damage from occurring, you reviewed and changed the management plan, and you introduced new strategies, you accessed all the equipment and the additional support services, then actually you could say that was an unavoidable pressure ulcer. Now there's a lot of content in the protocol, and like I said, it is worthy of a look and for you to have your own copy. But really, what can you do? My advice really would be to make sure, as we all know, that every service user is risk assessed for pressure damage using the Waterloo or another NICE recognised tool. Make sure that those people that are at risk have a really robust care plan that details the risk, how it will be managed, and in particular focus on those individual risk factors to that person. And make sure it's reviewed regularly, or if there is a change in condition, and consider alternatives all the time when you review. Follow best practice recommendations, and there is plenty out there for how to prevent pressure damage and to promote good skin integrity, and I definitely direct you to the NICE guidelines for that. And make sure you have access to equipment and that it is appropriate for use. A really, really important factor is where a service user declines any intervention or doesn't want to follow recommended guidelines, make sure that you do evidence that you have tried to educate them on the consequences to really aid informed decision making. And if there is a service user who's at risk of neglect, say for example due to cognitive decline, then take that multidisciplinary approach, access those services that you need to get that support, and considering the need to inform safeguarding of the risks you've identified. And finally, as we do through good governance, we've already mentioned it earlier, but collect data in your service of pressure damage prevalence and act on any themes and trends that you find. So there's a constant, continuous improvement cycle going on in your service. Now, Philippa, I've chatted over this very, very quickly, but I appreciate it's a very clinical document, and would recommend that it could be used as a resource in any way that meets the service. So if it's not maybe so relevant in your service, you could use it as an audit tool perhaps, but what's your thoughts?
Yeah, definitely, and I think it's worth it, for example, if you're a domiciliary care provider,
yes,
having a look at it. But I think, you know, good pressure care goes back to the basics in domiciliary care. It's about when somebody starts with your service that you have good baseline assessments, you use a Waterlow score if you're delivering personal care, that you benchmark against that score, so you're doing proper reviews of somebody. And I think it's also, we talked about people's rights and balancing risk and positive risk taking. But it's things like refusal of care in relation to pressure sores. Now, people have a right to refuse care, and where they have capacity, they may not want to have a wash every day. But I think good communication is essential here, and that staff are escalating where they've got concerns, and that if they aren't able to go in and to wash somebody or deliver the care as planned. Because if you're not washing somebody and you're not involved in their personal care, and you've been asked as part of the care plan to do that, then you don't know what's happening with their skin integrity. I've been involved in safeguarding incidents where carers have not been able to deliver a care as planned because somebody keeps fully dressed when they arrive in the morning and say, don't worry, I've had a wash, you don't need to help me. And then down the line they find that they've got a pressure sore or a pressure ulcer. So I think it's really important where care staff and to train new care staff to report and to escalate concerns where somebody's refusing care, or where you have concerns about somebody's skin integrity, that it's documented, and you work with the wider disciplinary team, multidisciplinary team. So you're in constant contact with district nurses, you're in touch with GPs, to get their involvement. So it's not just a clinical approach. You know, domiciliary care providers do have a really important part to play in relation to preventing pressure ulcers. And I think, you know, it's not a bad thing to be reporting concerns. When I was involved in clinical governance, I used to get quite concerned, or very concerned, when I would go to a branch that hadn't raised any complaints. And the assumption that people are happy because there are no complaints is sometimes a misnomer. We are dealing with humans, as I said earlier, and things will happen. I think CQC have taken steps in terms of how they manage emerging concerns. Leah, do you want to talk about the emerging concerns protocol?
Yeah, definitely. So this was commissioned by the Health and Social Care Regulators Forum, and it's been developed by a number of regulators, as you can see. And the whole purpose is to aid sharing of information of concern in a timely manner. It was only released at the end of July, but the protocol can be accessed via the CQC website now. So again, I'd recommend you have a look. Dental, I think, are going to be joining the forum in the next few weeks, and the work itself was endorsed by NHS England and NHS Improvement. And currently this protocol only covers England. Like I said, its aim really is to facilitate sharing of information at an early stage so that links between concerns can be made. And there are concerns that they've identified fall into three categories. So one is about concerns around an individual or a group of professionals. Another element is concerns about the actual healthcare system or the healthcare environment. And this can include a learning environment for professionals. And finally, if they have any concerns that might have an impact on the trust and the confidence in professionals or a profession. It's very much about only sharing information on a need-to-know basis, and it should never become a personal data sharing issue. So all organisations there that you see, they have signed up to comply fully with legislation. And as we know, CQC, the regulator, relies on intelligence of others to form risk ratings of our services. And by using this protocol, there can be a timely review, as I've already mentioned. I think probably now would be quite a good time to talk about some practical elements of safeguarding, Philippa. So do you want to start talking about positive risk taking?
Yeah, I will do. I'm mindful that Leah and I have given you an awful lot of information in the last half hour. You have got a section on your screen for questions. It's on the little box on the side. If you do want to ask any questions, we are live. Yeah. It's not, you can't pause us, it's not like Sky Go, but you are there able to ask us any questions, and we will try and answer questions as we go through the rest of the Q talk. So do feel free to ask us anything. So what do we mean by positive risk taking? And on a practical level, we need to consider for a moment the day-to-day support that we provide to service users in our services, and how we can implement positive safeguarding of adults to reduce the chances of abuse and harm occurring. And we've got a quote on the screen here from Lord Justice Mumby. It's going back a few years, 2010, but I think it was a really good quote about what good is making someone safer if it makes them miserable. And I think, you know, there's a saying, nothing ventured, nothing gained. And this makes the point that unless someone takes a risk and tries new activities, they'll never know the positive benefits that might result. And everything we do carries an element of risk. So I got it this morning, I drove to work, it was a little fraught, all the school kids were back, the M4 was particularly bad, but it was a risk. But I knew what the risks were, I knew I wanted to get to work, and I've weighed up the risks. And it's the same for service users. We talk about doing risk assessments, and if you go through CQC inspection reports, you can see where it said the provider has a robust process in place for managing risks. They involve the service user, they seek the service user's views. But I think there's sometimes the risk that we become overly protective, and that we have perceived ideas about what's because of someone's illnesses or disabilities, that there are limitations in someone's abilities, or the fear that they may be harmed. And I think where people have capacity, as providers, we have a responsibility to allow people to take risks, but it's about positive risk taking, that we've given them the information or signposted them to the correct information, so that they can make those decisions for themselves and weigh up the balance of, is it safe for me to do? Well, sometimes people make decisions that we don't always agree with. I was talking to Leah earlier about an example. I was in a case I was involved in a number of years ago with a service user who abused alcohol, and it was a very, very complex case. And looking through in preparation for this presentation, I could see that it wasn't actually just an isolated incident, it had happened in other parts of the country as well. And the service user was wanting care staff to buy alcohol, and the man had capacity. And I think there are issues where somebody misuses alcohol, that if they don't have access to alcohol, it can make them more vulnerable to people coming around and trying to sell them alcohol, and it could lead into lots of other things as well. So there was a real balancing of risks there with the staff. And unfortunately, this gentleman died. And there was an inquest, and the coroner wanted it to say in the final report that the care staff shouldn't have been buying alcohol for the service user. And the local authority were actually really strongly advocated on behalf of the service user in this case, and that emphasised that the service user did have capacity. He would have been at more risk, and it was a balanced assessment. They obviously, there was the risk of, were they enabling his alcohol abuse? And as I say, it was a complex case, but it was about positive risk taking. And in the end, the coroner didn't actually document that. So positive risk taking, as I say, is about weighing up the potential benefits and harms of exercising choice. And it's about weighing up the risks and trying to find a balance between the risks and benefits of a particular decision or action. So we have to involve service users in this, and that's again going back to the principles within the Care Act, the safeguarding principles. It's about including people in decisions and enabling them to be involved in decisions about their life. I think there's a report, No Decision About Me Without Me, in relation to mental health services, and it's really important we look at that. I'm going to talk a little bit about other aspects of safeguarding, practical approaches. I've been involved over the years in a number of care awards. One of my favourite categories is actually the Care Worker of the Year awards, or Care Worker awards. And when the organisers for the events put together the questions, one of their favourite questions is, can you tell me how you've gone the extra mile? And it's a really nice question, but for me, from having a safeguarding background, it actually sometimes gives me the EBGBs. I don't think it's because I'm particularly risk averse, but I think sometimes there's a very fine line between going the extra mile and something tipping into a safeguarding issue. And an example of that was one that a number of years ago, we were bouncing around the subject of care workers taking a service user back to their home for Christmas dinner. And nobody liked the idea of a service user being on their own, being lonely and isolated on Christmas Day. But taking a service user home for Christmas makes me wonder, what happens if they haven't cooked the turkey properly and it makes them ill? What happens if they take the service user in their car? Have they got the correct amount of insurance? What happens if the service user offers them money and the care worker takes the money for the Christmas dinner? And there's a whole host of scenarios that need to be considered. And what I'm saying is, we shouldn't discourage care workers from going the extra mile, but I think what's really important is making sure that you have systems and processes in place, not only to protect the service user, but to protect your organisation and to protect the staff as well. So have you got the right processes and procedures in place to manage financial transactions? Have you got procedures in place to manage how to manage medication when the service user is away from home, to prevent neglect or omissions arising in a service user becoming unwell? I think that, Leah, you've got some good examples as well from some inspections that you can probably draw on.
Yeah, if I draw on my experience in the inspections, I think everybody who's taking part in that inspection does actively look for examples of a really positive culture for risk taking. So a recent example would be where a resident was supported to make, it sounds really simple, but to make a cup of tea. And there is obviously a risk of scalding there. And we observed that that person was supported really well by a colleague, but they were unable to do that. And when you looked in their guidelines within their care plan, the care plan was structured in such a way that it really did focus on their own abilities first and their wishes and their preferences to make this cup of tea. And then it followed with what support was needed. And the practice observed and the care plan written, they correlated and worked really well together. And I do read a lot of inspection reports, and you can achieve anything. You know, I saw a really good example on an outstanding home, not surprisingly, but they supported service users to climb trees, skydive, you know, the world's your oyster. You can do whatever you want with really effective, positive risk taking. Yeah.
Okay, so we're getting a number of questions coming through, which is great. We're going to do a little poll in a minute. We've got a question here about what's this document called.
We've discussed a few.
Yes.
So if we talk through quickly what we've discussed. We've discussed the Department of Health pressure protocol, and that can be found really easily on Google.
Yeah.
The CQC document,
emerging concerns, is on their CQC website.
It is.
And the RCN document for competencies and training we can make available on our website as well. It's actually a little bit tricky to find, and we can make sure that you have access to that as well. So there's a lot of other questions coming through as well. I just really wanted to ask you, though, while we're going through looking at the questions, whether you, listening to the webinar today, have had to submit any safeguarding incidents, and if you have, whether you think there were positive outcomes for service users. So I think the question is a yes or a no again, and it's yes, have any safeguardings arisen? So if wait for these answers to come through, Should we just quickly go through some of those other questions you've got there?
Okay, so somebody's asking about any good recommendations for training on positive risk taking. I would first of all check out the Skills for Care website. They have got some really good resources there, especially a learning to live with risk document. That's quite good that you could adapt that for training. And again, revert back to your care certificate workbook because there'll be elements within that.
Okay, that's cool. Somebody's just asked me about the Christmas scenario.
Okay.
And what I would suggest there is making sure that you've got really clear professional boundaries documented, and you include that right from induction, and you revisit it during supervision and during training. I think professional boundaries cover such a wide area. It links back to professional codes and care worker codes of conduct, but things, for example, care staff often have smartphones, but what happens when they run out of data? Is it acceptable for care workers to log on to somebody's Wi-Fi? Well, actually no, it's not, but staff need to understand these things, and having a really good framework in terms of professional boundaries sets out very clear parameters for staff to work within, and it prevents any grey areas arising. So in terms of the poll, well, we've got 100% answering yes.
Fantastic.
And I think that, that's a really positive thing, that, it's not positive that safeguarding incidents are rising, but it's a really important sign that providers are recognising when there are signs and indicators of abuse, and that they're taking action to do that. And I think from a CQC perspective, I think that's a very positive sign that people are submitting safeguarding notifications and contacting local authorities, or contacting the regulator as well.
Yeah, definitely. And just to reinforce really the making safeguarding personal document, there's key questions now about how we reflect on the whole safeguarding process, in particular to the individuals that were involved, and we should be asking them for their feedback on the whole experience and how they found that safeguarding experience.
Okay, so thank you for joining us today. I'm aware we've covered an awful lot of information today. As I said at the start of the webinar, we don't have all the answers. It's such a huge area. It's an area that we're all learning constantly, and we wanted to share some of our thoughts and ideas with you. The webinar is going to be available for a short time on our website. It will be in the form of a YouTube video, so if you do want to go back and recap over anything that we've talked about, please do feel free. QCS is follow us on Facebook, on LinkedIn, on Twitter. We will be doing another webinar in the next month. We are anticipating we're going to talk about good governance, because this appears to be an emerging theme with CQC. So I look forward to you joining us all next month. Thank you for signing in today, and it's been great that so many of you have joined us. So from Leah and myself, thank you very much, and enjoy the rest of your afternoon.
Thank you. Bye.
Bye.